So basically today imaging is very, very important. It's always a class 2 indication. But what I feel is probably you should realize, especially OCT should be given a class 1 indication, especially in stent failure. That is what is our real-time clinical experience, as well as probably, since we don't have much of evidence, it's a class 2A indication. And he has dealt with all this, causes of stent thrombosis, early, late, and very late. We are all familiar. And these are the trials which have shown the main reasons for stent thrombosis, residual stenosis, stent edge dissection, tissue prolapse. And coming to stent thrombosis, very important, it is acute and late. So this is basically a late stent thrombosis that what Singutwil showed. And the most important causes are neoatherosclerosis, uncovered stent, and probably hypersensitivity. These are some of the important reasons which have. As Dr. Sheth said, probably if you deploy the stent properly, your late complications will be less. So this is an example, a patient who comes with an ST elevation MI after an BVS deployment. 3.5 years after BVS deployment, he comes like this at the middle of the night. So what we do is we do a thrombosection, and then after the thrombosection, this is the finding. And he was just stable, ST settled down, and then he was brought back 1 month later for a check angiogram. So he was not willing for anything on that initial sitting, but 1 month later, this is the check angiogram that you see here. So for such a lesion, should we do anything now, or just put them on medical management? What is the issue here? So angiogram wise, we really just cannot make out anything what is happening. So now look at this OCT. OCT clearly shows that there are areas of malapposed struts here, and significant areas of under expansions you can see, and there is neointimal hyperplasia. And to just because of the lack of time, I'll just go to show you the slides, still images also. When you look at the neoatherosclerosis here, it is an homogeneous type of atherosclerosis that you see predominantly after a BVS implantation. Unlike our DES, most of the time it's heterogeneous, but here you see it's homogeneous. And of course, we had a doubt, so we did a FFR, and FFR was positive. So this patient was stented with a long drug-eluting stent with a good result, with excellent position and area there. And this is another example. A patient comes to us with a stent thrombosis 1 year after angioplasty. And he was thrombolized outside, and 6 hours after the thrombolysis, he comes for an angiogram to our center, and this is the angiogram here. So you don't find anything here. Predominantly, what we used to do for such cases, we used to say is probably developed a thrombus, successful thrombolysis, again put them on a dual antiplatelet and send him. So, but here, when you do the OCT, see exactly what you are seeing is, I'll go to the still images. Yeah. So there are clear-cut areas of malapposition there with endothelization and thrombus attached there. And when you just analyze, look at the EL there, and then look at the stent size there, there is clear underexpansion of the stent here. So which you really could not pick it up on an angiogram. This was only post-dilated with an adequate size NC balloon, and the patient is still on follow-up doing very well. And the post-dilatation, you see that malapposition is well apposed and it is well cleared there. Another case here, Sahu was showing about the stent boost, like what you see here. But here in this case, when you see here, probably you think that there is an underexpansion in this area. So, but when I did an angiogram, when I did a OCT, that is not the scenario there. Stent boost might be good, but that may not be perfect. So you see here, actually the underexpansion area is here. This is the minimal stented area. But area what we saw it on the stent boost was here. But probably if you take a stent boost in 2 angles, probably you may not see that abnormality there. But it clearly showed that it's an underexpanded area here, which we treated with the NC balloon. And post-NC, you see here, it's a very good expanded stent and going on well there. And to just the next thing, proximal stent apposition where there was a disease. So I'll just go a little bit faster. This was an acute stent thrombosis. In this, the one day after the primary angioplasty, he had a stent thrombosis. So when you do an OCT, you see a clear malapposition. See, malapposition, if it is so gross, definitely causes a problem. You just can't ignore that. You cannot make out anything about malapposition on an angiogram. Very difficult to pick up on angiogram. OCT clearly shows that there is an area of significant malapposition which was dilated with a balloon, and the patient is doing well. And now, coming to, we have so many other examples and cases. I'll be a little bit faster. This is an interesting case here. One patient who had a stent thrombosis, and angiographically it was looking completely normal. A VIP patient was referred to me to just make out what is the cause for the stent thrombosis. And here, OCT clearly shows all the factors. See, distally there is a major dissection, and there is a malapposition and a stent under expansion, all in a single case, which angiographically we were thinking is normal. So that is why this patient had a stent thrombosis. So this is very, very important to pick up, and of course was treated with one more stent there. And coming to the present scenario, like what Sengatuvel has shown, look at this patient, it is something like that. And Giulio was clearly pointing out that there is something wrong there. You look at this stent edge there, and then this case is almost similar. This is 1.5 years after LAD getting stented there. And RCA had a disease, and when we did the imaging, so this is what you see there. Just concentrate on this OCT. There are areas of intimal hyperplasia and areas of malapposition, huge malapposition you can see here. And there is actually the stent is just floating there in the coronary. So when you see this with angioregistration, just concentrate on this white mark, how to just dissect your coronary and look into the pathology. See, there are areas of underexpansion and hyperplasia and significant malapposition here, a great malapposition at that area. And again here a malapposition, and overlapped areas are there in this case here. So this is what we see on an imaging very clear. Another similar case. So this is 1 year after stenting, and you see the OCT here. OCT clearly shows what is happening. So it's a huge aneurysmal reaction to that stent which has gone there. So I have put a covered stent in this case there, and then after the covered stent, you see the OCT finding, and OCT is like this after a covered stent. See, what happens is you just cannot see anything behind the covered stent. You just see the bright thing here. So behind you feel it is something like a lipid, but it's because of the covered stent that what you are getting here on this OCT here. And this is the last case I will just show you. So this patient, again, 2 years after stenting, he had a finding like this. And in the stent, you can see here what has happened is there are areas of acquired malapposition like this. So this patient, what I did is I just put a bigger balloon, dilated, and just left it like this. He's doing well. So you, for a case like this, you can treat by probably the first case I sent him for bypass surgery. The second one I put a covered stent, and here I just post-dilated this case and then just follow up. And this was that malapost area where we just dilated. Thank you very much.